By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another episode of Nets Get Real. I'm your host, Mike Wayman. Today, we have Dr. Heloisa Soares from the University of Utah joining us. Before we get into her and her presentation, got to remind everybody that hashtag the Zebras Take Atlanta 2022 NCAN National Conference is this November 10th through 12th. It's taking part in the Marriott Marquis. We're going to have over 20 NET specialists on hand to share presentations, answer your questions. So registration is open. Go to netcancerawareness.org for more information, as well as all of our social medias at netcanceraware. So now I'd like to bring in our guest today, Dr. Heloisa Soares. How are you?
Good, and you?
Very good, very good. Thank you so much for joining us. If you wouldn't mind, can you just let everybody know a little background about yourself?
All right, sounds good. Well, first of all, thank you for having me. I'm delighted to join you today and share a little bit about me and some of the important work that I think we're doing in the field. So, Heloisa Soares, I am originally from Brazil. That's my accent. Did my med school there, and then came to US, did research for a few years, my residency, and then in Florida, and then my fellowship at UCLA. When I finished my fellowship, I actually joined Moffitt as a mentee of Dr. Jonathan Strasberg. I was with him for a few years, and then have been different places, including New Mexico, where I'm super proud that we're able to take PRRT to the patients there. And now I am at the University of Utah when I lead some of the efforts in neuroendocrine tumor neoplasms, and also now direct the clinical trials office to continue to bring a lot of exciting research to our patients. I have been taking care of patients with NETs and neuroendocrine carcinomas for probably now about 8 years. We have some trials that I think are very exciting to our patients. And I am very passionate about patient advocacy. Every time that one of the cancer organizations, the ASCO, which is a clinical oncology, American Society of Clinical Oncology here in the US, goes to Capitol Hill, I try to join to really try to advocate for patients. That's a part of my calling that I really enjoy as well. So love to be with patients and educate patients.
That's great. That's great. Now, what actually led you to becoming a NET specialist?
I have to say it was a little bit of chance, because I always wanted to do GI cancers, and at the time we were interested in going back to Florida, and Dr. Strasberg had position that he was looking for early career or a junior faculty to help him. And I said, sure, let me learn more about neuroendocrine tumors, because as you all know, it's a rare disease that we don't see very often. And even during fellowship, you might not have as much exposure. I did have an amazing mentor in UCLA that was, they saw a lot of NETs, but not with the level of involvement that I had at Moffitt with Dr. Strasberg. And then as I started taking care of these patients, they really, took my heart. is is an amazing community. Patients are so engaged, which I love because I love answer questions. I love the challenges, and then I was like, wow, I want to really do this when I grow up, and that's how I joined the field. But it was a little bit of the timing and the chance and the opportunities that I had when I joined.
Perfect. That's great. Now, why do you think it's so important for patients to be involved with their treatment plan?
Because they're the best advocates. This is a disease that can have very unique or non-specific symptoms that providers in the community might not think about neuroendocrine tumors as part of the diagnosis. So the more patients get educated to help with their own diagnosis is important. So they have to be their self-advocates. And when they already have the diagnosis of the disease, I think is important for them to know what's going on in the field to make the right choices, right? Patients will get, thankfully, we have many treatments for this disease, but the question is, when is the time to trigger a new treatment? And having them involved in the decision is extremely important. So that's why I think it's mandatory for patients to have education in the field. Not to mention that if they are having their care in the community, they can bring their providers up to speed with some of the quote-unquote cutting-edge research that's going on, or even new treatments that are coming around that a provider that doesn't focus in NETs might not know.
Yes, yeah, absolutely. That's one thing that we have to kind of work on is trying to get the providers up to speed, because they're just not. They just are not.
Yeah, I think it's not to their fault. It's the field of oncology is moving so much, right?
Yes.
I'm very humble to acknowledge that I probably wouldn't be able to be a general oncologist, just because when you think about all the advances of melanoma, there are so many when you think about advances of lung. So it's really hard as a general practitioner to be up to date with every single aspect of oncology. But that's when the experts in the field have a vital role to engage with the community and be available to be able to share their knowledge that someone might not have, just not because they're interested, just because so much. I wouldn't be able to be a general oncologist.
Now, in regards to proper patient care, what do you think is the most important decision a patient can make?
Finding a care team, and it's not about one person, finding a care team that they trust and feel comfortable to reach when they have questions that are important in terms of managing symptoms that are not appropriately managed, or change decisions on timing of changing treatments and what treatment. So finding the care team. And again, I strongly believe that this is a care team disease that is not about one person knows it all. I always discuss my patients with my colleagues from other specialties, because they bring different aspects to the care that I might not have been necessarily thinking about.
That's great. That's great. Now, so what are you going to be talking to us about today?
So when I was thinking about it, I was like, well, I think we always discuss diagnosis, we always discuss symptoms. I'm sure you have plenty of physicians discussing treatment options. So I said, why don't I talk a little bit about chances of the cancer coming back after there is a resection, and what we have been doing to try to see if there's anything that we can do to minimize the chances of a tumor to come back. And because we have a little bit more data for pancreatic neuroendocrine tumors, that's what I'll be talking about, a little bit about what are the chances of recurrence after a patient has a resection for their pancreatic neuroendocrine tumor, and what is available to be done afterwards, if anything, and what is a trial in the field, which I'm involved via SWOG and then cooperative groups mechanism from the National Cancer Institute.
Excellent. All right. So without further ado, the floor is yours.
Thank you. All right, everyone. So let's hear a little bit about recurrence risk in pancreatic neuroendocrine tumors. So as you probably are very well aware, pancreatic neuroendocrine tumors are only about 1 to 2% of all the pancreatic neoplasms that we see in the field. So most of the patients that say that they have pancreatic cancer do not have pancreatic neuroendocrine tumors. It's still a very rare disease. And in terms of the incidence, probably there's about 1,000 new cases any year of patients that have been newly diagnosed. Thankfully, most of the patients that are diagnosed with pancreatic neuroendocrine neoplasm are actually diagnosed with a neuroendocrine tumor, which tends to be a well-differentiated tumor with a low to intermediate grade of activity. So they tend to be a little bit more indolent. They're not most of the time extremely aggressive. The only way to cure patients that have localized pancreatic neuroendocrine tumor is only having a surgical resection of the tumor in the pancreas. There's no other way to cure a patient. Unfortunately or fortunately, the disease behaves in very different ways, and the management can be a little bit controversial in terms of timing of things. And, if someone has a large pancreatic neuroendocrine tumor, there's any role to doing chemotherapy before? We don't know, because we don't have large trials for that. And also, if someone has pancreatic neuroendocrine tumor that has a spread for few places in the liver, is there any role for resection? There's a lot of debate on all that, but if someone has a localized pancreatic neuroendocrine tumor, they absolutely should consult with a surgical team. And the current recurrence rates are a little bit variable, and I'm going to show you. This is some data that was generated from Dr. Singh from Canada. They look at recurrence risk after resections of GI neuroendocrine tumors. And then you can see here in this table, when you look at all comers, 92% of the patients will be alive in 3 years, and up to 50 years is 54%. When we look at incidence of recurrence, in 3 years for all NETs is going to be about 23%, in 5 years, 33%, and in 15 years, 58% in all comers. And when we look at pancreatic neuroendocrine tumors, you see that the rates of recurrence are a little bit higher. And that's not surprising, because when we compare pancreatic neuroendocrine tumors to small bowel tumors, we know that the pancreas ones tends to be slightly more aggressive. So again, when you take all comers that had resection of their pNETs, there is 26% chance of recurrence based in this database. And we often tell patients that we need to follow them for at least a good 10 years, because even though many of these tumors will recurrence early on, there's a chance up to 10, 15 years after that they can still come back. And that's why we follow patients for a minimum of 10 years, if not even more. And that's a little bit different from many other cancers, right? That you might hear saying, oh, my doctor says that if my cancer doesn't come back in 5 years, I'm done. I don't ever have to worry about. Unfortunately for NETs is a little bit different. And I just wanted to show this graph to help to explain why we follow patients for much longer. So, and then what are the risk factors? What are the things that might suggest that a tumor might come back when we look at, particularly in this case, pancreatic neuroendocrine tumors? So a group of institutions from the US, about 10 of them, that they call themselves the USNet study group, they look into that. And what we could see from their studies, they look at about more than 1,000 patients, is that patients that have positive lymph nodes at the time of resection of the primary pancreas tumor, they will have a little bit of a higher risk of recurrence. There was a discussion about whether or not you have what's called a R0 resection versus a R1 resection. And what is that? Our R0 resection is when the margins, when the surgeon cut the sample to separate normal tissue from cancer tissue, that there is enough space that there is no quote-unquote disease left behind. When there is R0 resection means that when the pathologist looks under the microscope, they might see still cancer cells next to the final cut towards the end of the sample. So it could have, that means that maybe some microscopic tiny little cells of cancer were left behind. What is interesting is that even though there might be some suggestion that R0 resections might impact recurrence, that happens much later on. It's not something that happens right away. So that's something that we don't focus a lot in some of the discussions, because if this happens, will happen much later. Size of the tumor can also be something that can impact the recurrence. The larger the tumor, the higher the chances of the tumor to come back. And the group also developed what's called a predict score that suggested that patients that have a high score will have a much higher rate of recurrence within 2 years. And the rate of recurrence is up to 33% in patients that have this high score. The main trigger of someone having a high score is to having grade 3 pancreatic neuroendocrine tumor, meaning that when we look under the microscope, the Ki-67 that you see in the pathology report is higher than 20%, and is still a well-differentiated tumor. This is the UCLA experience. They look into 4 different predictors or prognostic factors, I should say, that help us to stratify patients. And the tumor size was an important one. And here they felt that tumors that were bigger than 5 centimeters were the ones that will suggest that someone will potentially have a recurrence. Positive lymph nodes, the Ki-67 here, definitely above 20%, and the ones that have a Ki-67 between 8 to 20, which is still a grade 2, also had a little bit of a higher recurrence rate, and they look at 5 years here. So few studies have been done, and this is a poster and an abstract that was presented at the European Neuroendocrine Tumor Society. They're looking to several studies that have been published to try to understand the risk of recurrence. And the bottom line is that they say that potentially many of these tumors will recurrence within 2 years, especially if they have some of the features for recurrence. Again, I don't want to go into all these studies that have been done, but just to give you a taste that many of these studies that have been published in the field do suggest that there is between 20 to 35% chance of tumors having a recurrence after they were resected. Also, we know that tumors that are metastatic, for instance, the tumor started in the pancreas and had spread to few places in the liver. If we go and resect the pancreas tumor and at the same time resect the liver tumors, or in a later stage resect the liver tumors, we know that even though we might be buying time and quote-unquote resetting the clock, because it's going to take a little bit of time for these tumors to come back in the liver, most of the time they will come back. And some studies have been shown, taking all comers, that the half of the patients after the resection of the liver mets, the tumors can come back in 15 months. And that's the median recurrence rate from 3 studies. So when we were trying to see if it was important to figure out a way to decrease the chances of recurrence, we try to understand where does these tumors come back to. And many times they do come back in the liver, and again, tend to be within 36 months, as you can see here, versus coming back in the pancreas only, or in any other place. Another thing that when we were trying to understand which strategies we can do to decrease the odds of recurrence, and then some of the discussions that we have was like, well, it doesn't matter if the tumor comes back. Are we impacting the survival of the patients? If we treat them after the resection, does it change how long they're going to live? Because thankfully, again, many of patients live for a very long time, and perhaps it's not going to affect survival of the overall survival of these patients. Well, when this U.S. Neuroendocrine Tumor Group looked at their database, they saw that no, actually patients that had the resection and did not have a recurrence live longer than the ones that had a recurrence. And that was an important argument to justify that we needed to do better, and we needed to develop strategies that maybe will improve the chances of these patients never having a recurrence and never dying from this cancer. This is a little bit of the rationale of why we can consider resection of the liver metastasis. Even though the tumors come back, they might come back later, and patients tend to live longer. But we know that most of the time, even with the resections, the tumors, unfortunately, within 5 years will come back. And that's a slide that I borrowed from Dr. Kyochen from the University of Chicago, and I appreciate this slide. So then the question is like, all right, if we know that the tumors come back, if we know that if we avoid them from coming back, we might actually impact survival, is there any role to do anything after surgery to decrease the odds of the tumors to come back? Well, there's not a lot in the field out there. There is this real-world experience from 3 centers in China that treated patients with somatostatin analogs after the resections, and they showed that maybe we could be impacting these patients with using some sort of systemic strategy afterwards. And that was uncontrolled study, but give us a hint that maybe there is something that we can do about it. So what are the options that we can use to perhaps decrease the odds of a tumor to come back in the pancreas? Well, we have the somatostatin analogs that I mentioned to you before. We have everolimus and sunitinib, which are pills. They're target therapy in a way that have been approved for the treatment of stage 4/metastatic pancreatic tumors. But all these 3 medications, they don't necessarily kill the DNA. They don't kill the cells, the cancer cells. They stop them from growing. And if we wanted to fully eliminate them, perhaps using something more cytotoxic that actually kill the cells will be a way. And how do we do that? With potentially chemotherapy. Other options will be, what about immunotherapy? We see folks talking about immunotherapy for so many cancers, and in fact, there are many other cancers for which after a resection, we use immunotherapy to decrease the odds for the cancer to come back. Unfortunately, all the data that we have in the field from control research in neuroendocrine tumors that are well differentiated have shown that immunotherapy is disappointing. We have not been able to move the field further using immunotherapy in the well-differentiated neuroendocrine tumors. Yes, we can use in the little bit more aggressive tumors, and there's data for that, but in the slow-growing, the data that we have really has been disappointing. So even though many patients back in when immunotherapy came around might have used it, now as more studies come on board, we know that's not the best choice. And what about PRT, right? Can you use Lutathera, PRT, or any of the new strategies that can be done to do this target radiation to the tumors? Well, number one is very costly. Number two, we are learning more and more about the possibility of long-term toxicity, and one of toxicity that we always worry about, and I call it the biggie, is the risk of developing acute leukemia, or MDS, which is a cancer in the bone marrow. And that's that if this were to develop, is most likely fatal, right? Acute leukemia is a very serious disease. And also, we don't know how much that will truly affect the tiny little cells that might have left behind. So we don't have enough data, I'll say, to support, for now, the use of PRT. And maybe with the new radioisotopes that are coming along, maybe this will change. So we felt when we were brainstorming about how we can decrease the odds of a recurrence, that cytotoxic chemotherapy or chemotherapy would be the way to do this. And Dr. Coombs and ECOG group, which is again a cooperative group that's part of the National Cancer Institute, actually had conducted and had results about the use of capecitabine and temozolomide, which are oral cytotoxic chemotherapies for the treatment of metastatic advanced stage 4 patients. And her team and her group had showed that using capecitabine and temozolomide for pancreatic neuroendocrine tumors actually improve the survival of patients, and most likely, and also improve the timing for the disease to start growing. So this was extremely important because it was a control study that showed us that CAP10 impact the outcomes of patients. So we decided that maybe the best way to try to decrease the odds of these tumors coming back after resection of pancreatic NETs was to use capecitabine and temozolomide. These are some of the side effects of the drugs. Most of the time, it tends to be related to issues with the blood counts, particularly with the white count and the platelets, and some nausea and vomiting can be seen, particularly nausea with the addition of the temozolomide. And obviously, with the two drugs, you have a little bit more fatigue than just one drug. So based on that, SWOG 2104 was developed, which is a phase 2 randomized trial of evaluating the role of capecitabine and temozolomide versus observation, which is the current standard of care in patients that have high risk for recurrence. And again, as I mentioned before, it takes a care team to take care of patients. It also takes a team to develop these studies. So I'm very appreciative of all the efforts. These are some of the folks that have helped, and Dr. Saeed Hamed at the University of Cincinnati has been fundamental in supporting this trial and developing this trial, in addition to many others, including Dr. Strasberg, Dr. Desari, and all other champions that you can see. So again, takes a village. This is not one person effort. So in this study, what will happen? Patients that have a resection of their tumors in the pancreas, and potentially plus or minus a resection of few liver mets, if they only had liver mets and the liver mets were all resected at the time of the initial surgery, they could be considered for this trial. And the patients then will receive the chemotherapy pills for 4 months versus being randomized to observation, which is right now is the standard of care. So outside of a clinical trial, if a patient has a resection of the pancreatic neuroendocrine tumor, even if there is some high risk features, we do not truly know if doing anything after will impact the odds of the tumor coming back. So we don't recommend any systemic treatments afterwards. We recommend observation, or another way to say this is surveillance, and the patient should be getting scans every 6 months for the initial 3 years after. And then after that, annually. And normally we do up to 10 years, right, total. For the study, we'll follow these patients to up to 6 years. And randomization is done by a computer, but is essentially flipping the coin whether or not a patient that elected to participate in the study will receive the chemo pills versus will just be followed with scans. I do not have a control over who gets what, neither the patient. Is really a lottery or quote unquote flipping the coin. And the goal of this study is to see, does using chemotherapy for 4 months decreases the odds of recurrence within 3 years, as we saw that many of these patients will have recurrence in 3 years. And who is electable for the study? Someone they had their resected pancreatic well differentiated tumor. It can be a R0 or R1 resection, so microscopic disease could have left behind. If this is a R2 resection, meaning there is macroscopic disease, the surgeon knows that they left tumor behind, then these patients are not eligible. Because we know the Ki-67 plays a role, the Ki-67 of patients has to be between 3% and 55%. If it's more than 55%, that means that's a very aggressive tumor, and perhaps we should think of different strategies. And this is a little score that has been developed by the U.S. Neuroendocrine Tumor Study Group to try to stratify patients. And anyone that had a score there is a 3 or above is eligible for this study. Also, if patients, in addition to the resection of the primary tumor, had resection of liver mets, as long as the patient only has 3 liver metastases or 5 liver metastases or less, they are allowed to participate in this study. But it has to be at the same time. It's not what's called a stage resection. If the patients had the resection of the pancreas at one surgery, and then fast forward 3 months later, they have the resection of the liver metastasis, that is not someone that is eligible. It's only if the patient goes for the all resection up front and did not receive any treatment before, with the exception of somatostatin analogs. So if someone received chemotherapy before going for the resection, they are not eligible for the study. And patients with the poorly differentiated tumors that are more aggressive tumors, they are also not eligible for the study because they could be considered for a different treatment strategy. And patients with germline mutations or syndromes that they were born with, one example is M1, are eligible for the study as well. We are only taking patients that are 18 years or older. So this is not something that we are developed for the pediatric children population. So that's what I have. Thank you so much. I just want to give you an overview of the risk of recurrence after pancreatic neuroendocrine tumors, hopefully explain a little bit of the rationale of why we should follow patients for longer than 5 years, and share a little bit of the efforts that are being done in the field to maybe do better.
Thank you so much, Dr. Soares. That was a great presentation. If everybody likes that kind of content, please make sure you like and subscribe. please make sure you join us at our conferences. Come to the Atlanta National Conference, November 10th through 12th. Go to your local chapter meetings. We have stuff all over the NCAN YouTube, and I believe there is another presentation by Dr. Soares on there as well. And we can't wait to hear more of the things that get developed between now and then at the national conference. Everybody, please make sure you like, subscribe, do the thumbs up, give a 5-star review. It helps beat the algorithm. What we want to do is create awareness for this disease. So how do we do that? We beat social media. We beat the algorithm. So make sure you follow us on the social medias, Net Cancer Aware. Go to our website, netcancerawareness.org, for more information on all of our events and to find your local support group chapter. And thank you once again for joining us on Let's Get Real with NCAN. We'll see you next time.
Thank you.